Bismillahirrahmanirrahim. Assalamu alaikum warahmatullah. Today we're going to continue with infections of the respiratory system, and we're going to talk about some other bacterial causes of infection, such as Pseudomonas aeruginosa, and other bacteria which cause atypical pneumonia, such as Mycoplasma pneumoniae and Legionella pneumophila. We are going to start with Pseudomonas aeruginosa or P. aeruginosa. And as we can see, it is gram-negative bacilli, and as we can see here on the culture media, that it has colored pigments and is capable of producing multiple pigments, as we're going to see in a moment. So Pseudomonas aeruginosa is considered the motile, and it is motile and has a unipolar flagella. It's a gram-negative rod. It's obligate aerobe, and it's an oxidase and catalase positive microorganism. Pseudomonas can be grown on a wide range of culture media because it has minimal growth requirements and is capable of producing pigments such as the pyocyanin pigment, which gives a blue color on the culture media. The pyocyanin pigment is released by the bacteria and is taken up by the nearby cells. It leads to reactive oxygen species, and it leads to oxidative damage in the cells which have taken up the pigment, and it leads eventually to cell death. Also, it's capable of producing fluorescein, which is a yellow pigment, biorubin, which is a red pigment, and bioverdin, which is a green pigment, which when released can extract iron from the neighboring area and serve as an iron chelator. Also, Pseudomonas aeruginosa produce characteristic grape-like odor in the infections which are associated with Pseudomonas aeruginosa, and can be recognized also by the color of the pigment, which can be seen within the infection sites, such as the infection which are seen in the wounds or burns patients. Also, the Pseudomonas aeruginosa is characterized by having a broad antibiotic resistance, so it's advisable before starting any antibiotic treatment to take culture and sensitivity, and to make sure that the Pseudomonas is going to be susceptible to the antibiotic given for the patient. What are the structural components in Pseudomonas aeruginosa? First of all, it has the pili, or the hair-like or the tufts, which are on the surface of the bacteria, and these pili adhere to the host cell and help in attachment of the bacteria to the host cell, especially the ciliated cell in the respiratory tract. Also, the bacteria has an endotoxin, or the lipopolysaccharide, which plays a role in inhibiting antibiotic killing and suppress neutrophil and lymphocyte activity. Also, the bacteria is capable of forming an alynate, or what we call biofilm. The biofilm is a gel-like sticky material, as you can see here, and this prevents the immune system and antibiotics from targeting the bacteria which lie underneath, and makes the bacteria more resistant to antibiotic, and the immune system is not capable of phagocytosing it. Also, as we said, the pyocyanin, which is the blue pigment, which can be released by the bacteria, and it's going to be uptaken by the nearby cells. It's going to produce oxygen radicals, which is going to lead eventually to cellular death. The Pseudomonas aeruginosa is present in the environment, especially in the water and soil, and is present everywhere in houses, in the hospitals as well. In the hospitals, on the catheters, on the uncleaned ventilators, and it is part of the normal flora in certain healthy individuals. 2 to 10% of healthy individuals might have it as a normal flora. Once they cough or sneeze, the microorganism might escape from their nasopharynx, and if someone is in close contact with them, they might take up these aerosols and go to the nasopharynx and cause infection in the respiratory tract. Pseudomonas is considered an opportunistic infection. That means it's not capable of infecting healthy individuals. It mostly infects those who have chronic illnesses or who are immunocompromised, such as patients with cystic fibrosis, cancer patients such as leukemia patients, and patients with extensive burns. The microorganism requirements for growth are minimal, and it can survive temperatures between 20 and 42. As we said, in the hospitals, it can be found on respirators, ventilators, humidifiers, and it can also contaminate medications and contact lens solutions. Can transiently colonize the respiratory and GI tract of hospitalized patients, those in the hospital with suppressed immune system. It can infect both the GI and the respiratory system. In patients with cystic fibrosis, the infection with Pseudomonas aeruginosa becomes chronic, leading to high morbidity and mortality rate, because in those patients, it's going to be difficult to treat, and the Pseudomonas is characterized by multiple drug resistance. The infection with Pseudomonas aeruginosa can occur all year round. Pathogenesis of infection with Pseudomonas aeruginosa. So first of all, there needs to be a break of the first line of defense, such as the skin break in case of deep wounds or burns patients, or contaminating solutions such as contact lens solutions, so that they can get into the eye. The infection starts by attachment of the pili of the bacteria to the target cell, and the bacteria also can produce the extracellular polysaccharide, and in certain types are in the ventilators or catheters, they can form biofilms to protect them against sterilizing effects. What are the virulence factors of Pseudomonas aeruginosa? We have multiple virulence factors such as exotoxin A. Exotoxin A has a structure which is similar in a way to diphtheria toxin, composed of an AB, and it eventually is going to affect the elongation factor 2, which is going to eventually inhibit protein synthesis and leads to cell death and lysis. And we can see it in the burn wounds, in the corneal damage which occurs as a result of infection with Pseudomonas aeruginosa, in the ocular infections, and in the chronic pulmonary infection. We have also the exoenzyme S, which is going to affect the protein synthesis and is going to lead to interference with the host cell growth and eventually death. And it leads to cellular destruction and spread from burn wounds. Also, we have elastase enzyme, which leads to destruction of the elastin containing tissue, such as in the blood vessels, lung tissue, skin, collagen, immunoglobulins, and complement factor, and it can produce hemorrhagic lesions associated with spread of the infection. Also, it's associated with the endotoxin or the lipopolysaccharide, which is going to elicit strong immune response, and as a result of this strong immune response, the damage of the immune system is going to be on the host cells. Also, it has a phospholipid base C, which is produced by Pseudomonas aeruginosa, and once it gets into contact with the target cell, it's going to break the cellular membrane and leads to tissue destruction and death of the target cell. What are the clinical diseases which are caused by Pseudomonas aeruginosa? Pseudomonas aeruginosa cause a wide range of diseases, which could be as simple as folliculitis and as severe as endocarditis. So folliculitis can be seen in hot tubs because the bacteria is capable of contaminating hot tubs, and folliculitis, as we can see here in the picture. In case of folliculitis, this is a self-limiting infection and does not need any further intervention. It can cause pulmonary tract infection, and we're going to talk in detail about pulmonary tract infection in Pseudomonas aeruginosa. It can contaminate wounds and burns and lead to Ecthyma Gangrenosum, as we're going to see in a moment. It can lead to UTIs, external otitis, Otitis externa, which is the infection of the external ear, eye infections such as conjunctivitis, and it might lead to corneal ulceration, and it can lead to valvular endocarditis as well. In pulmonary infection, the infection could range from asymptomatic colonization to severe necrotizing bronchopneumonia, and colonization is seen in patients with cystic fibrosis. As we said, it's an opportunistic infection, so the patient had to have a pre-existing condition such as chronic lung disease, cystic fibrosis, or neutropenia. The strains are commonly isolated from chronic pulmonary patients, are more difficult to eradicate, and in these cases, in the cystic fibrosis, the infection with the Pseudomonas strains is associated with multi-drug resistance, and it is difficult to get rid of the infection with Pseudomonas aeruginosa. What are the predisposing factors for pulmonary infection? Therapy with broad-spectrum antibiotics, use of respiratory therapy equipment such as ventilators, and in these cases, the mortality rate with Pseudomonas aeruginosa is going to be very high, which approaches 70 to 75% in these cases. Another infection, as we said, is the Ecthyma Gangrenosum, and this is seen in patients who have deep wounds or who have extensive burn patients and who are bedridden. So the Pseudomonas is going to cause infection into these lesions, and as we can see, and it would eventually lead to what we call black necrotic ulcer. These patients are usually immunocompromised, critically ill patients, and the lesion starts with a blister, but eventually is going to lead to an ulcer with tissue necrosis, which we can see here on the margins, blackish coloration, or here in the mid of the lesion. Also, it can lead to malignant otitis externa, or the external infection of the ear. Mostly it's seen with diabetic patients. Also, it might contaminate, as we said, the contact lens solution, and it might lead to conjunctivitis. and in complicated cases it might lead to ulceration of the cornea within 24 to 48 hours. Also, it might lead to infection of the tricuspid valve, leading to tricuspid valve endocarditis, especially in patients who are IV drug users. So how to diagnose patients with Pseudomonas infection? First of all, the clinical picture or presentation and the chronic illness or the immunocompromised state that the patient has is going to be a guide for you to think about Pseudomonas aeruginosa, especially in the respiratory tract patients with cystic fibrosis. So once you hear about a patient with cystic fibrosis with lower respiratory tract infection, the first thing that should come to your mind is Pseudomonas aeruginosa, especially if the patient has taken antibiotics with no response. Treatment diagnosis: oxidase positive colonies capable of producing pigments such as cyanine, and it can grow in a range from 20 to 42 degrees. We should do culture and sensitivity testing, acquire samples and send for culture and sensitivity, and in cases who have taken previously antibiotics without any improvement, we should look at the sensitivity testing in order to give the appropriate antibiotic. Also, we need to look at the CBC and look for increase in neutrophil count. Treatment: as we said, Pseudomonas aeruginosa is characterized by drug resistance and sometimes multi-drug resistance. It's resistant to antibiotics such as penicillin, ampicillin, tetracycline, aminoglycosides, and sulfonamides. And you can start the patient on therapy, and while on therapy he can become resistant to that antibiotic. This is a characteristic with Pseudomonas aeruginosa. It produces beta-lactamases, so can't be used with beta-lactam antibiotics. Third generation cephalosporin, carbapenems, and monobactam, they are the drugs of choice as a single treatment, but there are regimens for multiple therapy for Pseudomonas patients as an anti-beta-lactam and an aminoglycoside, or a carbapenem with fluoroquinolone and aminoglycoside in the resistant cases. There is no specific vaccine for Pseudomonas. The second microorganism that we're going to talk about is Moraxella catarrhalis, which is a gram-negative aerobic coccobacilli, and it is non-motile. It grows on blood or chocolate agar. Moraxella catarrhalis is associated with two types of clinical syndromes. In healthy individuals, it could be part of the normal flora, and it could cause infections such as sinusitis and otitis media, especially after viral infections of the upper respiratory tract. And in the elderly and immunocompromised, it is associated with chronic pulmonary disease in the form of bronchitis, mostly bronchitis, and in certain instances it might cause bronchopneumonia. Treatment, prevention, and control. Most strains of Moraxella catarrhalis produce beta-lactamases, so they are penicillin resistant. In this instance, there are multiple antibiotics that can be used to treat Moraxella catarrhalis infections, such as amoxicillin, clavulanic acid, second, third generation, cephalosporins, fluoroquinolones, and erythromycin. So if we look at the growth or the colony of Moraxella catarrhalis on the chocolate agar, we can see it is a creamy color colony. The microorganism is catalase positive and oxidase positive, and as we said, it is penicillin resistant. The third microorganism that we're going to talk about today is the Mycoplasma pneumoniae. And the Mycoplasma is unique in that it lacks the cell wall of bacteria. The plasma membrane is the outermost part of the organism, and is unique among bacteria in that it has a high content of sterol that act to prevent osmotic lysis and prevent the bacteria also from taking the gram stain. It's very small in size, so it can be comparable in a way to viruses. Also, it shares another characteristic of viruses. It's an intracellular microorganism. It's non-motile and it may have a capsule. Although some are free-living, most are closely adapted parasites in that it needs to or it lives intracellularly. It grows on media enriched with serum, needs cholesterol in order to grow. Grow best at 35 to 37 degrees, either aerobically or anaerobically, so it's a facultative anaerobe. The Mycoplasma pneumonia requires 1 to 2 weeks in order to grow on culture media, and once grown on the culture media, the eaten culture media, it gives a fried egg colony. Also, there's a way of staining with the Diene stain, and it's going to give the fried egg appearance as well. The mycoplasma has multiple virulence factors. It's not invasive and simply colonizes cell surfaces through specific binding. So it binds specifically to the cilia in the bronchus via the surface mycoplasmal cytoadhesion or the P1 protein to sialic acid receptors. Leading to interference with the ciliary action and results in its death and desquamation. Once there is damage to the host tissues, the immune response rather than invasion by the organism. So the damage of the host tissue is mostly by the immune system response to the presence of the mycoplasma within the ciliated cells. The organism is shed in the respiratory secretions for 2 to 8 days before onset of symptoms and continue to be shed for up to 2 weeks after the symptoms disappear. What are clinical infections which are caused by the mycoplasma? Tracheobronchitis in children. 60% of the infections caused by mycoplasma are seen in children in the form of tracheobronchitis. Also, it causes pneumonia, and 10% of all cases of pneumonia are caused by mycoplasma pneumonia. It's a cause of an atypical pneumonia, and it causes what we call walking pneumonia because the patient in most instances does not need to be hospitalized, so he's going to be ambulatory and in the community. It's transmitted mostly by aerosols or droplets and mostly infect children aged between 5 and 15 years of age. In this age group, the infection is more severe. After 2 to 3 weeks of incubation, the disease begins as a mild upper respiratory tract infection, and then it might progress to fever, sore throat, headache, malaise, and dry cough, which is usually mild and self-limited, though certain investigations such as the chest X-ray, as we're going to see in a moment, might look more severe, but in most instances, the clinical picture of patients with atypical pneumonia, especially as a result of mycoplasma pneumonia infection, they look good and they are in good shape and health. It might also cause pharyngitis. It might cause also otitis media, and in patients who, especially children who have atypical pneumonia, the infection might spread to the brain and it might lead to encephalitis, and those patients might present with fever, neck stiffness, and change in mental status. So if children present after atypical pneumonia with mycoplasma with these signs, we should think of encephalitis as a result of mycoplasma infection. How to diagnose mycoplasma? Uh, First, we can isolate them in culture, but it requires requires a long period of time. We're talking about 2 to 3 weeks on Eaton's agar, and it looks like a fried egg colony. Also, we can do serological testing and say for fourfold rise in a specific antibody titer. Also, we have a sample bedside test that can be done. It is non-specific testing, but in this instance can give us an idea whether it's mycoplasma or not. It's called the cold agglutinin test. And the principle behind the cold agglutinin test is that the mycoplasma has an antigens that might mimic antigens on the RBCs. So if we take a blood sample from the patient and then put it in a bucket of ice to lower the temperature to 4 degrees, then the antibodies which are formed against the mycoplasma might stick to the RBCs and make them agglutinate. This is a sample test, can be done bedside. It is non-specific, and early in the disease, the antibodies might have not formed, so it might give a false negative result. Also, the chest X-ray, as we can see in this chest X-ray, we can see here there's a consolidation, here a consolidation. This is for a patient with mycoplasma pneumonia. So once we look at this chest X-ray, then we might think that the patient is in very bad shape, but actually the chest X-ray in mycoplasma pneumonia looks way worse than the clinical condition of the patient. The patient might be doing well, but the chest X-ray is looking worse. How to treat mycoplasma pneumonia? Mycoplasma pneumonia can be treated with tetracycline, macrolides such as clarithromycin, azithromycin, and quinolones, and macrolides are considered the drug of choice in the case of mycoplasma pneumonia infection. The last microorganism that we're going to talk about today is Legionella pneumophilia, and it took its name, or its name was derived from the incident or the gathering that this microorganism was first isolated in. So there was a U.S. Legion Convention in Philadelphia in 1976, where the U.S. war veterans, المحاربين القدامى, they were meeting there. And after the convention, it was found that multiple of those U.S. war veterans had suffered pneumonia, lower respiratory tract infection, and they dig deeply to look for the cause, and they found that the AC towers were contaminated with this microorganism, and it was the microorganism responsible for the pneumonia which was seen in those patients. So it was called Legionella. It's a small gram-negative pleomorphic rod. Pleomorphic means that does not have a specific shape, and it stains poorly with a gram stain. It can be stained better with diethyl stain. It is motile, requires cytosine, requires cysteine, ferric ions, and pH of 6.9 for growth, so it does not grow on ordinary media. In fact, it has a special media which is buffered charcoal yeast extract, and it contains cefamandole, anisomycin, and polymyxin B to exclude the growth of other types of bacteria. In this picture, we can see that the media for the growth of this microorganism, and we can see the colonies which grow on the buffer charcoal yeast extract media, and it has a ground glass-like appearance, which is distinctive for Legionella pneumophilia. It grows in enhanced and growth is enhanced within the presence of 2.5% CO2. The growth might take up to 10 days to be seen, and as we said, it has a ground glass appearance colonies. The virulence factor for Legionella pneumophilia is that it inhibits phagosome lysosome fusion, which allows for intracellular growth. So it inhibits the fusion of the phagosome and lysosome, and as a result, it can survive within the phagosome. The lipopolysaccharide of Legionella is less toxic than the other gram-negative microorganism, and it's going to be responsible for one of the manifestation of infection with Legionella pneumophilia, which is the Pontiac fever, as we're going to see in a moment. It inhibits generation of bactericidal substances in phagocytic vesicles, especially the hydrogen peroxide, so that it can survive within the phagocytic cell. What are the clinical significance or the clinical manifestations which are seen as a result of Legionella infection? It can cause either acute pneumonia, and this is the severe form of infection with Legionella, or a mild form, which is Pontiac fever, that we're going to talk about in a moment. So, as a result of the presence of the bacteria, is going to lead to acute pneumonia, or what we call Legionnaire's disease. This is transmitted via airborne transmission, and it requires incubation of 2 to 10 days. In this case, the symptoms include, as any atypical pneumonia, fever, chills, malaise, myalgia, dry cough, and it can be associated in certain instances with diarrhea, vomiting, and abdominal pain. Hospitalization is usually required in 3 to 5 days. But hospitalization is not a must in all patients. Legionella, by the way, causes 2 to 9% of the lower respiratory tract infections annually, and a small percentage of those require hospitalization. If not treated with proper antibiotics, there is a high chance of death with Legionella infection. The disease occurs more with patients who are aged above 60 and those who have immunocompromised status. It does not transmit the infection from one person to another. Rather, it should be contamination with water resources or AC towers or ventilators with the microorganism Legionella pneumophilia. The disease rate after exposure is low, so not everyone who become infected with Legionella is going to become ill, and the reservoir of infection is the cooling towers of ACs and hot water lines, as well as in soil and water. The other form of the disease, the mild form of the disease, is the Pontiac fever, and it is self-limited febrile illness with incubation of 24 to 36 hours. In fact, the illness or this clinical picture results from the sensitivity to the Legionella components, or as a result of reaction to the endotoxin of Legionella, and it is characterized by fever, chills, malaise, myalgia, and headache, and it lasts 2 to 5 days, and as we said, it's a self-limited, so does not need to be treated with antibiotic, unlike the pneumonia caused by legionella. If not treated with proper antibiotic, it's going to be associated with high mortality. How to diagnose infection with legionella pneumophilia? We have urinary antigen for serogroup 1. Also, we can inoculate into the buffered charcoal yeast extract and the chocolate blood agar and look for growth versus no growth. So we're going to see growth on the buffered charcoal yeast extract versus no growth on the chocolate agar. Also, it's catalase positive, and we can use also direct fluorescent antibody testing and PCR testing in order to diagnose infection with legionella. The treatment of choice is macrolides, clarithromycin or azithromycin. Also, fluoroquinolones can be a good choice antibiotic to treat legionella infection. How to prevent the legionella infection? Minimize production of aerosols in public places, and it might be resistant to chlorine and heat, so it might be not easy to get rid of. So that's it for this lecture. Thank you for listening.